like their certificate for this, we can also give you one of those. So, and I would like to introduce the wonderful Dr. Zimmerman, who will be doing our presentation today. Dr. Zimmerman.
All right, thank you. Sorry, it looks like we had a little glitch in our internet here for a second, so hopefully things will go along as planned. My name is Kate Zimmerman. I am one of the emergency medicine and EMS physicians here at Maine Medical Center, and I'm going to be talking to you today about tracheostomy management for EMS clinicians. I have no financial disclosures. The only disclosure I have is that I'm very fond of dogs, and we can do advanced emergency treatment, I would say, in our canine colleagues coming up pretty soon as we get our protocols rolled back out. So my objectives for you today, by the end of today's session, you should have the tools to help you successfully troubleshoot the majority of tracheostomy emergencies that you may face. And in order to achieve this overall objective, you'll need to understand the variety of and anatomical differences of the surgical airways you may encounter in the field. You should be familiar with the patient's tracheostomy equipment. And I'll give you an overview today of the basics, but I will tell you that there is a variety of different equipment that's out there. So I highly suggest that if you know that you have folks in your catchment area that have tracheostomies, it's important for you to engage with them and their caregivers and be proactive. And you'll need to be able to recognize tracheostomy emergencies and to respond in a systematic way so that you're able to help these patients in their time of need. These are high acuity, low occurrence events, so HALO events, at least for you in the pre-hospital setting. However, up to 40 to 50% of folks with trachs will have some minor complications, and then some will proceed to pretty significant complications. A half of the deaths that do occur in patient with trachs are because of dislodgement or decannulation of the trach itself. So let's talk about surgical airways, because this tracheostomy is a type of surgical airway. The most familiar surgical airway for you, I would imagine, would be the cricothyrotomy, right? It's one that our paramedics can perform in the can't oxygenate, can't ventilate scenarios for our patients. Often there's been significant upper airway trauma or anatomic changes or distortions that obstruct the airway and prohibit us from using bag valve mask adjuncts or blind insertion airway devices or endotracheal tube management. Just to review, we have our basic landmarks with our thyroid cartilage. This is where, particularly in males, you can feel the Adam's apple. And then below this is the cricoid cartilage, which is the only fully circumferential cartilage that is in the airway. Those are our landmarks, and we're going into this cricothyroid membrane. When we place these airways in the field or in the emergency department in an emergent fashion, we understand that these are not long-term airways. There can be scarring or injury. They're up near the cords. And just keep in mind that the narrowest part of the adult airway is up near the glottis, and that in the pediatric is the actual cricoid ring itself. So for longer term airway management, the tracheostomy is utilized. The tracheostomy itself can be performed surgically, where they dissect down through the layers of skin and muscle, right down through the thyroid into the to the cartilage itself. In its eyes, the cartilage kind of tack it back and create the stoma. It can also be done percutaneously, through with bronchoscopy from above. So this often takes 2 or 3 folks to do. And this is done with an initial incision, some blunt dissection down, and then introducing kind of a needle and a dilator and placing a wire and directly visualizing via the scope or the camera that's up through the upper part of the airway. These are much more complex procedures and require multiple hands and direct visualization for both techniques. This is why we don't do these in the field. There are significant blood vessels in the area of the tracheostomy or of any of our surgical airways. And there are not only these vessels that feed the thyroid gland, which, you know, if we're doing our cricothyroid, if we're doing our cric, if we're going too far lateral, we may run into those. But when we're doing a tracheostomy, we're having to go typically between the second and third rings, cartilaginous, or actually cartilages of the trachea. Remember, below the cricothyroid membrane, the cartilage are C-shaped. There's no, it's all soft tissue in the back wall. And so here we've got a pretty heavy vasculature feeding into and out of the thyroid gland. I also want to show you, this is the superior vena cava, right, draining the subclavian veins. These are your internal jugular veins. And then deep to that, closer to the trachea, we have the large vessels. So we have the aorta, and the first big branch off the arch of the aorta. Aorta is this innominate artery, and this can sit right up against the trachea, and that will be, we'll discuss a little bit later how that can lead to complications. That innominate artery then feeds into the subclavian and the carotid. I just keep this in mind. This can lead to, as I said, complications, typically within the first 6 weeks, out to 3 months or so, with significant bleeding. Lastly, there's the patient who has undergone a laryngectomy. And in this case, the entire larynx is removed. So the epiglottis is gone, the glottis where the vocal cords are, the thyroid cartilage area, the cricoid cartilage is. And the trachea is pulled up to the skin where it's tacked down, and that's where the airway opening is, surgically created that way. This means that there's no communication between the oropharynx, nasopharynx of the upper airway to the lower airway. So if you run into problems, this stoma is the only place you have to go. You can't do anything from above in these patients, and these are really scary patients for any of us to have to manage. This is a side-by-side representation of the tracheostomy versus the laryngectomy. Over here is a normal airway. And so you can see oropharynx, tongue coming down. This is the epiglottis, right? Coming down into the larynx through the vocal cords, past the thyroid and cricoid cartilages and down into the trachea. Here, the tracheostomy bypasses basically the larynx. So we're coming in below here, and this is where your airway is going. If we were doing a cric in the field, we're right up in this area. So up just a little bit higher. And again, the laryngectomy, the larynx, all of this is removed, okay? And so basically this is your airway, it's lower only. You should be aware of why the patient has a tracheostomy, right? Because there may be issues with their upper airway that you'll need to be able to anticipate if you need to access that upper airway because of issues with the trach, right? So they might have some anatomic changes with strictures, masses, and other distortions. So getting that history from the patient or their family is really important. So why do patients have trachs? Many reasons, right? They may have vocal cord paralysis, which prevents them from handling secretions and kind of cough reflex. They may have the anatomical distortions that we talked about in their head and their neck with masses, or maybe it's congenital and how they developed. They may have had prior trauma or prolonged intubation with stenosis or narrowing of the airway. They may have had a high spinal cord injury and they're unable to use their musculature to help them ventilate, and they're ventilator dependent. They may have muscular dystrophy or other neuromuscular disorders that lead them to being vent dependent. And then kids can have all sorts of syndromes. They can have that lead to small airways. They can have a weak trachea that leads the trachea to collapsing when they're inhaling, and they need to have that airway splinted open and maintained with a trach. So now that we're familiar with why folks may have a trach and the anatomical position of the trach, let's look at the equipment. And first we'll start with the tracheostomy tube. And the basic trach has a tube, okay, and a flange, which you'll see here, which is this part lays up against the neck. And then there'll be a tie or something to secure the trach tube around the patient's neck. And so these little slots are where the tie goes through. The tube is hollow and air will move through it, and this is through which the patient will breathe. This obturator, this is used only when the trach is being placed, and essentially what it does, once it's in the trach, it blunts the end so that when the trach is being placed, it's not going to puncture that back wall of the trachea where the cartilage is not existent. Remember, as I said before, cartilage has a C shape as such, so that the curvature is in the front and it's kind of all soft tissue in the back. It also provides a little bit of rigidity so that you can help guide the trach in when you're placing it. The obturator, once the trach is placed, needs to be removed. It should never be left in, right? Because you're obstructing that airway. And trachs aren't a one-size-fits-all deal. They come in a variety of shapes, sizes, and materials. So they may have, they may be a single lumen or a double lumen. Single lumen is like the one that I just showed you. It's just this one lumen here. But the double lumen has an inner cannula, and this inner cannula slides right in. And it's important to note that these help. I'm happy when I see a trach with an inner cannula come in, because I know if there's some trach issues or obstructions, I can just pull that inner cannula out. I've still got hopefully a patent airway through the outer cannula, and then I can clean or address the issue with that. When folks get, if they have a dual lumen tracheostomy, they often come with two inner cannulas. They have to take the inner cannula out and clean it every day, so they may have one temporizing one while they do that. The other important thing is that it's the inner cannula here that has the 15 millimeter bag valve mask adapter to it. So if we're dealing with a tracheostomy emergency and you pull out that inner cannula, you're not going to be able to attach the bag or the vent to the patient. So don't throw that away. Make sure it's clean, or grab the other one if you need to hook it up to the BVM. Next, some trachs are cuffed, kind of like this one here. You'll know that they're cuffed if they have a pilot balloon. And you'll be able to tell if the cuff is inflated or not, depending on the status of the pilot balloon. If the pilot balloon feels like it's full, then that should mean that the cuff is up. This may be filled with sterile water or air. For our purposes, we'll just be putting air into it during a trach change, but for long-term trachs, they may have sterile water. It tends to maintain that tube a little bit better. So to your left, this is a dual lumened trach tube with a cuff. This is a dual lumen trach tube without a cuff. You can see here there are a couple different ways that this inner cannula will connect to the outer cannula, right? We don't want these sliding out. So they might either twist to lock in and these two little dots will line up when it's inappropriately, or there might be little clips or snaps for them. And then over here, we have single lumen tubes, and these are often used in the pediatric population and neonate populations because they have smaller airways. On these single lumen tubes, they will have a 15 millimeter adapter at the end of the tube already built in. And that, again, is what will hook up to your bag valve mask or your ventilator. The single lumen tube, as I said, is often used in infants and younger children because of the smaller diameter of their airway. There are some larger single lumen tubes that would be used in adults. These tubes are usually changed weekly, either by the family at home or while the child's in the hospital. They'll have had their first trach change done in the hospital, and then the parents need to show that they're competent at changing the trach before that child is sent home. When you are looking at these tubes, they do have information on them for you. So here, this is the trach size, this is a 3.5 Shiley, and it says no cuff. We also know that because we don't see any pilot balloon off of it. And then over here, for Shileys, a 3.5 correlates with the inner diameter. So like our endotracheal tubes, named for their inner diameter, so aren't the tracheostomy tubes. So the inner diameter is what you need to pay attention to, and then this is the outer diameter here. So with a small single cannula tracheostomies, there's nothing really to keep the stoma open when the tube is removed or if it falls out. So it's really important, particularly in kids, to get the tube back in and inserted as soon as possible. Another feature of the tracheostomy tube may be that it has a fenestration or a hole or holes in it, such as this one. And what this allows in this tube here, there's no cuff, it allows for when air comes up through the trach, it can pass out through the hole and go up through the vocal cords. And that will allow the patient to phonate or to be able to produce noise to speak. As you can imagine, these can become obstructed at the fenestration, being plugged up with secretions, or there can be kind of granulations that form if it's really up against the wall or there's irritation. I'm just going to point over here. This has fenestrations as well, which looks a little bit more like a colander. So there are different kinds of fenestrations. Tracheostomy tubes can be made out of different materials, right? We have some metals and some synthetic. So stainless steel or silver are kind of antimicrobial, just in their basic properties. These often are uncuffed, or they are uncuffed. They may or may not have a 15 millimeter adapter for a bag valve mask with them, and they may or may not have fenestrations. The PVC or silicone, as I showed before and we've reviewed, they can either be cuffed or uncuffed, and you can tell by the pilot balloon. They may or may not come with an inner cannula, and they may or may not be fenestrated. Suction catheters. So the other equipment that a patient with a tracheostomy will have, and that you need to have as well, and you should have on all of your ambulance, is suction equipment. So they'll have a catheter and a suction source. And because the tracheostomy bypasses the oropharynx, where the natural kind of humidifying and filtering occur, secretions can become pretty thickened. And so sometimes the patients will get kind of these hardened secretions or thickened secretions that will need suctioning, maybe increased suctioning. If that's the case, you can use some sterile saline. Put a few mLs into the trach prior to suctioning to see if that helps loosen things up. But folks don't routinely put saline down every time they're doing suction anymore. It was not found to be beneficial. What is the right size? Oh, so let me just, you guys should be familiar with this, but this is the suction catheter. This end hooks up to the suction source. You cover the hole here with your thumb often, and that will initiate the suction itself, allow it the suction to occur. And there are holes kind of along the sides of this tube. It's a soft, flexible tube. They come in different sizes, kind of measured in French. This is a sterile kind of enclosed suction catheter. We see these often with folks on mechanical ventilation. This part hooks into the trach. This end goes into the suction source. And there's a little button here that you push to kind of create the vacuum. And that's what initiates the suction itself. The catheter is within this sterile sheath. And then again, because this is hooked up to the endotracheal tube or trach, this is all clean and sterile. And then you can introduce saline into one of the ports if you need to. So what's the right size suction catheter to use? Well, one that fits the internal diameter of the endotracheal tube, right? So we know where we can find the internal diameter kind of written on the flange of the tracheostomy tube, excuse me. But our catheters are measured in French and not millimeters. So how do we convert that? If you multiply the internal diameter times 2, that'll give you the size in French. And you will use usually maybe a size below what you get, so that it's not like fitting so tight that you're occluding the airway even more. All right, so 2 times the internal kind of in millimeters diameter of the trach tube will equal the size in French. So you can grab that size in French and a size down. You'll need to measure the suction catheter. So if you have the inner cannula out, you can measure against the inner cannula. If they have the obturator around, you can measure against the obturator, or you can measure from the stoma to the sternal notch, and that should give you an idea about how far to pass that catheter. It's important that you don't go way down too deep because you don't want to cause any damage. You're going to end up in potentially a right main stem as well, and you don't want to do deep suctioning. When we do this as sterilely or as cleanly as possible. You're going to want to pre-oxygenate your patient, and then after you've measured how far you're going to put the catheter in, you advance the catheter, and then you apply the suction and kind of twist as you're coming out. And you can do this a couple times. You don't want to do this for more than 10 seconds at a time, because again, when you're doing this, the patient's not oxygenating as well. Other devices that you may see attached to the end of the tracheostomy tube, you might see this decannulation cap. This is a solid plug that goes onto the tube. That patient's going to be getting ready maybe to be decannulated in the future. So they may be just kind of breathing around the tracheostomy itself and getting ready. These are speaking valves, everything that's labeled as B. And these are one-way valves. So they allow air to come in, but they don't allow air to come out. So it's it should be a fenestrated tube or a tube with no balloon, so that the air can move up and around the tube or through the tube up through the vocal cords, and the patient can phonate. And this is called a Swedish nose, and it's got some foam in it, and it just kind of maintains the humidification of the breath. The patient should not have a decannulation cap or speaking valves on with a balloon up, all right, because air cannot move out, and if it's they're not going to be able to exhale effectively. And certainly if it's a speaking cap and a balloon is up, they can't get air in any case, or sorry, a decannulation cap. So now hopefully that we understand the parts and are familiar with some of the indications for the surgical airways, let's talk about presentation of the airway emergencies in tracheostomy patients. And I don't want you to panic. You already know what to look for with somebody with respiratory distress. So we'll just kind of go through the signs, and then we'll talk about kind of what to do. So, difficulty, you're going to get called for difficulty breathing. You'll see that the patient, as you walk through the door, may have increased respiratory rate. They might have that kind of fight or flight, kind of scared look, or they might be, they have altered mentation. They'll be restless or using accessory muscles. Little kids will have, look for the retractions. You may see change in vital signs with, tachycardia, high blood pressure. If in kids, if you're getting towards bradycardia, that's very worrisome, right? That's peri-arrest. And so the family members or caretakers are going to recognize this as being abnormal and call you. They'll also likely have tried some troubleshooting before you arrive. So it's important that you ask them kind of what they've done to try to solve the issue. This is a call where you're going to want to make sure you bring your equipment into the residence to the bedside, right? You're going to want your oxygen. You're going to want to make sure that it's not an empty bottle. You want to have stuff for the upper airway, so mask for oxygenation. Also a mask or something to place over the stoma for oxygenation. You're going to want your appropriately sized bag valve mask and suction equipment. And then you're going to want your other airway equipment. So depending on what level you are, you might need upper airway adjuncts. You might need a blind insertion airway device, endotracheal tube. You want your monitor with your pulse ox and end-tidal CO2 monitoring. And then you're going to want some friends to help you out because these can be really scary patients. The families will often have, hopefully, extra trach kits with them. They should have one of the same size of the trach that's in, and then they should have one size down. When you open these kits, they kind of come with all the pieces apart. So this is a single lumen kind of Shiley that we'd see in the pediatrics. And you've seen a picture of this already. So you have the trach here, you have the obturator, and this is the tie that goes around the neck. On this one, this is a larger Shiley for an adult, and this is a dual lumen with, it's got the two inner cannulas. So you just obviously will need one of those. It's got the obturator and the trach tie. And that's what you'll need. You might need some lubricant as well, just like we lube endotracheal tubes or nasopharyngeal airways before we put them in. So if they don't have this equipment, don't panic, okay? I'm going to walk you through an algorithm, kind of walking through all the troubleshooting. And then if you have to, you're going to do your BLS techniques, bag valve mask, bag valve to the stoma. If you're at the medic level, you may be able, or advanced level blind insertion airway device, or at the medic level endotracheal intubation. All right. So the common causes of trach emergencies, if you like mnemonics, here's one. This is dope. Otherwise, just think about the equipment that they have. Now that you understand kind of what the parts are, you can think about, what may malfunction and how to troubleshoot those. So the most common ones that occur are dislodgement, so partial displacement of the tracheostomy tube, or full decannulation where it's all the way out. The tube may be obstructed. Now, whether that's obstructed with sputum or scar or granulation tissue, a foreign body, like you may see that in kids. Somebody's, their little brother or sister stuck something down their tube. Or there may be a patient issue, right? Is there a pneumothorax or something even lower down? Because they're prone to barotrauma. Or do they have pneumonia or something else that's going on that's increasing their kind of oxygen demand? And then you can have equipment malfunction. Maybe the vent's not working or the oxygen ran out. So think about that stuff. So as you enter the house and you're applying, the first thing you're doing, right, is you're applying oxygen to the mouth and over the stoma. Gather some history and take a look at the trach while you're doing this. We're very good at kind of parallel processing, okay? Find out why that trach was placed, right? It'll give you an idea of any upper airway anatomy you might need to be aware of, because you may have to go from above. So it's nice to be able to anticipate that. Asking about when the trach was placed, it will let you know if that tract is mature or not. If the trach is less than 7 days old, you cannot change that, okay? You are at risk of dissecting down into the tissue between the trach and the outside here. And this should be only be changed by a person who usually it's the ear, nose, and throat physician or surgeon who placed that trach. because again, we don't want to create a false lumen. And as I told you before, the ENT physicians or general surgeons, trauma surgeons will do the first trach change themselves before those patients are discharged from the hospital. So just remember that, 7 days. You need to know the trach size, right? So you can look at the trach to get this info. And again, this is for figuring out what size suction catheter you're going to use, right? 2 times the internal diameter gives you the French. So it gives you the size of the suction catheter, and then go a size below that. Also, you want to know the size so that you can, if they have it, you can replace with the same size trach, and also have a size smaller. And if you don't have that, then you can, you need to know what size endotracheal tube that you might be able to put in through that stoma. Is the tube cuffed or uncuffed? You'll be able to see this again if there's a pilot balloon. And we'll talk about this as we go through the algorithm, because we may have to deflate that cuff. Obviously, if there's a cap or a speaking valve on, you'll want to remove that. And then consider end-tidal CO2 as you're going through and doing your initial assessment. You can put it over the mouth and nose. If you're getting a reading, you know that there is some patency of that airway, right? Of the trach and the upper airway. If you're not getting anything out of the trach for capnography, then that means that trach is obstructed. All right. So if the patient has a dual lumen trach, we're going to remove, the first thing we're going to do is remove that inner cannula. Again, you're going to have to look at it for a second to figure out how to separate it from the outer cannula. So either a twist mechanism or releasing a couple latches on the side. And then you're going to pass the appropriate size suction catheter to try to suction any secretions and see if the tracheostomy is patent. If you're meeting resistance before you're towards the end of the tube, then there is an obstruction. All right, so if you're successful and you're able to suction and pass a tube through the trach, we know the trach is patent. If not, then it's obstructed. Just a reminder on the suction, less than 10 seconds, suction on the way out, twist a little bit, make sure you pre-measure. So this is a picture of secretions in the trach tube, kind of creating some significant narrowing of that airway. And then passing the suction catheter, hopefully you can kind of clear that tube out. The common causes of trach obstructions, number 1, secretions, hence the picture on this slide for you. Normally the patients are able to kind of cough up and handle their own secretions with occasional supplemental suctioning. But if they are dehydrated or they've had a fever or an infection, they may become thicker or harder to handle. You may also see bleeding coming from the trach, which may be progression of just underlying disease placement, pneumonia. It could be from prior vigorous suctioning or traumatic insertion of a new trach. We'll talk about some other bleeding complications towards the end of the presentation. Could be obstructed by a foreign body, particularly in small kids, or the trach. If the trach itself is not obstructed, there could be something further down. And there may be just edema kind of around the end of that tube from vigorous suctioning or recent traumatic insertion of the tube. All right, so we've removed the inner cannula, we've tried suctioning, the patient's problem is not fixed, right? So we need to move on. If there is a cuff, we're going to deflate the cuff. You need to make sure that the pilot balloon is fully deflated. And again, just remember, there may be water, so you might be pulling water instead of air out. If there is improvement, it means that the trach maybe was partially displaced, like occluding the end of the cannula. I'll show you a picture to better illustrate this. And with the balloon down, the air can pass around the tube into the upper airway. And maybe you have some time to try to reposition that trach, or you could just maintain oxygenation from above and below and transport that patient and let us continue to troubleshoot. If the patient's vent dependent, it's really hard if you have to take that cuff down, because now you can't get any positive pressure like a seal for a good chest expansion. So you'll have to potentially replace that trach. That can be an issue. All right, so if there's no improvement or there's no cuff in the trach, then the trach is obstructed or dislodged, and your next step is eventually going to be to remove the trach. Now, this is what the stoma looks like. So this is a total decannulation. There should be a trach in there in this patient. This is kind of the partial dislodgement. So now you can see the balloon is up and occluding circumferentially around the airway here, and then the end is kind of up against the wall, so they're not able to move air. If you deflate this balloon, then the air can move up around the sides of the tube, and they can get some ventilation. So that tube may just need to be repositioned. Here, this is an example of a tube that's kind of created a false lumen or tract, right? It is not in the airway at all. So maybe it was recently, they just tried replacing it, and for some reason, they created this false lumen anterior to the trachea. So there's no airway here. They might be getting some air through here, but may not be enough for them. So just keep that in mind. All right, so now the trach, we've had to take the trach out. And from here, one of two things will happen. Patient will get better, which means it was a problem with the trach, and you can replace it with a new one if you're trained. Or it won't get better, and you're going to have to think of other issues, right? Is it a patient problem? Is there pneumonia, pneumothorax? If it's a problem, maybe it's a problem lower than the trach. Maybe there's been stenosis or some other mass or obstruction there. But you're going to have to try to manage the airway from above or the stoma with positive pressure. So you can do this one of two ways. Let me pull this up. You can place, this is a pediatric or infant mask over the stoma. This is a tiny LMA over the stoma to create a seal, and you need to close the mouth and the nose, and you can do positive pressure ventilation over the stoma itself, or you can place some moist gauze over the stoma and hold that there while somebody does bag valve from above. All right, so now we're going to have to replace that trach. Let's talk about that. Your patient, again, should be getting supplemental oxygen. That was the first step in this whole algorithm. And you're going to need to position your patient. They should be flat with their head, neck neutral or slightly extended. You can do this by placing a towel roll under their neck or under their shoulders. And this will give you plenty of space to work in the anterior portion of their neck. You're going to want to need to prepare the tracheostomy tube itself by putting the obturator in, okay, and lubricating the tube. And have the trach ties pre-staged. You may want to have it through one side already or underneath the patient's neck and ready to go. If the trach has a cuff, you want to test that cuff and pilot balloon like you would with an endotracheal tube. So you're going to insert the tube along the curvature of the airway. And I think of this, you know, you can either go head on and be able to, if you have enough room in the front, insert the tube kind of 90 and then slide it in, heading inferiorly. Or if there's a lot of extra tissue and not a lot of space in here, kind of think it like an OPA. Sometimes we go at a 90-degree angle off to the side and then turn as we put it down. Same thing. You might come to a 90-degree angle off to the side, start inserting, and then twist and turn. Okay. And once the tube is in, you want to immediately remove that obturator. Then if it's a dual lumen tube, go ahead and insert that inner cannula. So you can see these little wings will click kind of around the edge here. So you go ahead and put it in until it clicks. And then you'll inflate the cuff if there is one. So this is getting ready. It takes about 10 cc's. Again, feel the buoyancy of the pilot balloon and inflate that cuff. And then you're going to secure with trach ties or a commercial device that comes with it. And then try ventilating the patient, right? Reassess them, reassess their airway, their breathing, their, watch for chest rise and fall, listen to their lungs. You can do end tidal CO2, monitor their heart rate, oxygen saturation, etc. And then secure the tube. And when you tie the trach tie, just make sure you can get at least a finger breadth underneath, so that's not too tight and occluding venous return from the head. And it's good to sit those patients up at least 30 degrees, kind of help them, get them to just help with their lung expansion. I have 2 videos that demonstrate some of these, which I am a big fan of videos. These are on a website called MRAP, which is subscription. So I can show you these here, but otherwise you have to subscribe to get this information.
Dr. Jess Mason here with a patient in respiratory distress. Our first move was to administer oxygen and attempt to suction the tracheostomy. What we realized is that he didn't have an inner cannula in place at all, just the outer cannula. When the suction tubing is attempted to be passed, it gets stuck, suggesting an occlusion. Our respiratory therapist attempts to suction one more time without success, and then we prepare for a tracheostomy exchange. We confirm that this is a mature tracheostomy, meaning more than 7 days old, and there were no prior suction tubing is attempted to be passed, it gets stuck, suggesting an occlusion. Our respiratory therapist attempts to suction one more time without success, and then we prepare for a tracheostomy exchange. We confirm that this is a mature tracheostomy, meaning more than 7 days old, and there were no prior difficult exchanges documented. Otherwise, we could consider using a bougie or tracheostomy exchange catheter. This is a new uncuffed tracheostomy tube with the obturator in place, and that's the inner cannula. The tip of the tracheostomy tube and obturator have been lubricated. Not shown here, but nasal cannula oxygen can be applied throughout the procedure, and you should extend the patient's neck by using a roll behind their shoulders. Remove the tracheostomy following the curvature of the device, and place the new tracheostomy following its curvature. Remove the obturator and place the inner cannula. Secure the tracheostomy collar and provide oxygen. Placement can be confirmed with capnography or by scope if available. This patient's outer cannula was completely occluded, which is why it's important to use the inner cannula and clean it daily. I'm Dr. Jess Mason, and we're going to replace this patient's inner cannula of his tracheostomy. Remove the speaking valve, then slide out the inner cannula and replace it with a new one. It slides into the outer cannula, and this one twists into place. Other devices might snap in place. Replace the speaking valve. The inner cannula is meant to be removed and cleaned daily. Here's an example of one that was completely occluded in a patient who was only using the outer cannula.
Okay. Just making sure you guys can hear me, hopefully see the screen. All right, so those are just a couple examples. It's good to see kind of the equipment and what it may look like when you're trying to do a trach change and become a little bit more familiar with that inner cannula. All right, so if you're not able to do a trach change because of your scope of practice, equipment, etc., then you'll need to continue with BLS care from above or over the stoma. So I showed you the pictures of the pediatric mask or the pediatric LMA over the stoma to create the seal there. If you are not doing that and you want to go from above with a bag valve mask, again, just a piece of gauze, maybe wet gauze here, something to occlude the stoma would be fine. If you are, your alternative for our paramedics is to insert an endotracheal tube in through the stoma. Again, 2 times the again, you're going to use the same kind of internal diameter size. So if it was a 5.0 shyly, you're going to use a 5.0 tube. Have a smaller size available as well, and you want them to be cuffed tubes to help you secure. So you're going to measure how much you're going to put that tube in, just like you would measure the depth of your suction catheter. So if you have the dislodged tracheostomy tube, measure against that. Otherwise, you just want to make sure you're not going too far down in and intubating the right main stem bronchus. So you're going to go in through and come down to about the sternal notch or so. You shouldn't feel resistance. And if you are, you should stop. And another way you may do this is over a bougie. So you may insert a bougie and feel those tracheal rings along the anterior aspect and then pass the tube over that. You're going to look as you would for any confirmation for intubation or airway. You're looking for equal chest rise and fall, listening for equal breath sounds, making sure the patient's improving, checking your end-tidal CO2 and your pulse oximetry. And then you're going to, if you're putting an endotracheal tube in, you need to secure this. A lot of places say not to cut the tube, but if it's getting in the way or you're worried that's going to be dislodged, if you do cut this tube, you need to make sure you're cutting above where that pilot balloon comes out, so you're not cutting the pilot balloon. And the other thing is you need to, I always worry like trying to get the 15 millimeter adapter off, like when you actually want it to come off is difficult, and then getting it back in. So if you're able to like not cut it and leave it, that's fine. It's actually preferred. All right, so those were the kind of airway tube complications, but what other issues might we see? If our patient's on a mechanical ventilator or having been vigorously bag valved, we may see some barotrauma. If they're on a mechanical vent and they have high PEEP or PIP, which is peak inspiratory pressures, they are at risk of a pneumothorax. If they have intrinsic lung disease, COPD, emphysema, they may have a bleb or something that's popped. Or if, these folks can get into accidents and have traumatic injuries like any of us, right? So careful examination, looking for signs of a tension pneumothorax. And if they have a tension pneumo, then you need to do a needle decompression. And needle Ds are subject for our next webinar. So I'm just going to put a plug in there for you. It promises to be a great discussion. All right. Patient may have other issues. They could have a pneumonia. Vented patients particularly are at risk of infections, and patients with trachs, because we're bypassing a lot of the protective mechanisms that we have in our upper airway. Often they're less able to clear their secretions, and so they're kind of set up for infections. And they may have infection of the trachea itself too, which can cause some narrowing and issues with ventilation. This is a picture here, kind of a side picture. This is the sternum. This is the spine. This is the trachea, and you can see this significant stenosis here. All right, the bleeding. I promised you I would get back to this, and I know I want to leave a little time for questions. All right, so back to the anatomy. Trachea. Here's your tracheostomy tube with a balloon. Here's your aorta, right? Comes off your heart, feeds blood and oxygen to your body. This is that innominate artery, which sits right up against the trachea. Over time, a fistula, if there's been trauma during the insertion, or there's pressure of the balloon up against this area, there may be some erosion of that artery into the tracheal wall. And on the good bad scale, I would call that bad. All right, so these tracheoinnominate fistulas, they're very rare. They have like a 0.7% incidence, but a 90% fatality rate. 75% of them occur in the first 3 to 4 weeks. And half of those are preceded by a sentinel bleed. So they may have had a small bleed that maybe was attributed to overzealous suctioning or something of that nature. So these patients need to be looked at and they need to be worked up even with these small bleeds. These patients are sick. So what do you think you can do to tamponade this bleeding? The first thing, if you have a cuff tube or you want to get a cuff tube in there, whether it's from above, which can be difficult with the amount of bleeding that they may have, or through the tracheostomy, is overinflate this cuff, okay? If you overinflate this cuff, you may be able to get some pressure on the artery and help staunch some of the bleeding. If not, you can try some sternal notch pressure, or introducing your finger into the stoma and kind of placing some pressure anteriorly to try to pinch that artery up against between your finger and the posterior aspect of the sternum. If your finger is in the trachea, you should have ideally somebody intubating from above to maintain their airway. So I pray that none of you ever see one of these. Okay, so those are some of the complications. Do you guys remember what DOPE stands for? Right? We kind of worked through that. So decannulation or dislodgement of the tube, obstruction, pneumothorax, or patient issues. So we're up to E, and E is your equipment. So there's an equipment failure, right? You ran out of oxygen, the tubing is cracked, your vent battery died, or there's something wrong with the circuit of the vent, or there's obstruction in the tubing, something got kinked, and then, or, you know, your trach can break, your balloon can, the cuff can break. So there's all sorts of things that may occur. So kind of go from, like, walk yourself, if you've done all the trach stuff and you haven't found it and the patient sounds okay, kind of walk through the rest of the equipment. This is a piece of a trach, an old metal trach that broke off and is now in the patient's left main stem bronchus. All right, so there's DOPE. So the algorithm, just to review, first thing, oxygen to both the mouth and the stoma. You're going to inspect that tracheostomy, ask your questions. You're going to take that inner cannula out if they have one. You're going to try to pass that suction catheter. Remember, 2 times the internal diameter gives you the size of the catheter, and go a size below that. If you have success, then it's not a trach issue. If you don't, you're obstructed and we need to deflate the cuff. You've deflated the cuff and they've improved. Well, maybe it was partially displaced, but good, they've improved. Continue to transport them. If not, then this trach is either obstructed or dislodged and you need to take the trach out. If they improve with that, great. I think we're all happy, and we'll try to get a new trach in or secure an airway as we need to. And if it's not, you can try some positive pressure ventilation, and then you're going to need to intubate potentially from above or through the stoma. Now, curveball. If they have a laryngectomy, you don't have any upper airway choices, right? You are stuck with the stoma, so you got to intubate through the stoma. Another way to remember this are what are called the ABTs. So you can do airway, breathing, and then these core actions for the C's. So remove the cannula, suction, right catheter, deflate the cuff. And then the T's, so trumped by oxygen status means you assess the patient. And if the patient's oxygenating and improving with your interventions, you're good. If you have time to assess for other non-airway issues, that's great. Otherwise, you need to secure the airway. So then you'll need to take if they're not oxygenating well, you got to take that tube out and either get an airway from above or below.
Kate.
Yes.
We've had a question in the chat, which is, what if they have a total laryngectomy with this type of bleeding?
Right. So if they have a total laryngectomy with that type of bleeding, this is a really scary patient. If you're able, it depends like how big that laryngectomy is, but you can try kind of pressure from above into that sternal notch. But I would try putting a tube in and overinflating the cuff and praying that that works. Just to remind you guys, you do have a tracheostomy care protocol that Dr. Scholl wrote, and I've gone through and looked at this, and it correlates with everything that I have told you today. So I think that's good. And just there's the table here with some of the types of trachs and the internal diameters, and if we have one type of tube, how does that correlate to another type? as well. So those are helpful hints. Right. So in summary, you at some point will take care of a trach patient in your career. I had one just a few months ago, and we're troubleshooting and this and that, and I had forgotten to just remove the inner cannula. I think, you know, if you're not doing these every day, you can forget that stuff. So, you know, print out the algorithm. That if you look up like the green algorithm for trachs, that's the one that I've been showing you, and stick it at the, you know, put it in your ambulance, or print out the trach protocol that we have, just to kind of help you. But, you know, familiarize yourself, do hands-on training, do simulation. I will never forget that. So if you do these kind of high stress inoculation kind of simulations, you're much likely to remember it the next time. Understand the complications of the dopes, like kind of the common problems that we see. And then, you know, follow your stepwise algorithm as we talked about today. If you need more information, I would go to the National Tracheostomy Safety Project. This is out of the UK. It's a great website. There's a ton of information on there. They have this algorithm, which correlates with what we've discussed today. They also have one for a laryngectomy patient as well, and it's worthwhile taking a look at. So just, you know, you can Google that and get onto their page, and they have all sorts of educational, there's some videos and some handouts. Those are just some other references from today's talk. And that's it. Any other questions or comments? It's a lot of information. I just can't stress doing practice and simulation. So my hope from today is that you guys reach out to anybody that's in your community that has tracheostomy and take a look at their equipment, talk to them, let them educate you, be prepared. Great. If you guys, I think Eric's going to put a link in the chat for feedback. Please be brutally honest. We want to tailor these talks to you and what you need. I would love for this to be like a hands-on lecture where we had our hands on the trachs, but obviously we can't do that. Otherwise, please provide the feedback that you can. And so you can either scan this QR code. Oh, great. Eric just put the link in the chat for you. And then you're testing my tech savviness. All right, here we go. Here is to register for the next class, which is going to be, as I said, on pneumothoraces, needle decompression. And I believe that's with one of our Dr. Shurtleff. Is that correct, Eric?
Yeah, that'll be Dr. Shurtleff and Dr. Scholl.
And Dr. Scholl.
Dr. Zimmerman, thank you very much for this today.
Yeah. Thank everybody for taking time out of your day and coming to listen to me. I know it's at 3 p.m. on a Thursday, or now 4. Thank you.